You should see it by now. Huh? Ang haba, no? So it's like we have 119 slides for our first part. Don't worry, mabilis lang to. Sorry, I have to close this. Okay, those who wish to turn off their videos, you may do so now, but I hope to see you once I'm done. Okay, so we start off with Staphylococcus and Streptococcus. So for midterm, you'll have all topics will be discussed. All topics that will be discussed will be under bacteriology. So bacteria kayo ngayon for the whole midterm. So we start off with Staphylococcus and Streptococcus. So ito muna, staph first. So this belongs to the family Micrococciacea. There are many species of Staphylococcus, but there are 3 or 5 medically important ones. These are aureus, epidermidis, and saprophyticus. Okay, so the lecture will focus on these 3 species, but predominantly Staphylococcus aureus. No? So Staphylococcus are part of the normal human microbiota of the skin and the nasal cavity and even the gastrointestinal tract and even the genitourinary tract, colonizing about 1/3 of the population. They are usually harmless but can otherwise cause infections once they gain access to the circulation via an open wound, a cut, or an abrasion. Although most people have antibodies to staphylococcal products, these are generally not protective, and multiple bouts of infection can occur. Morphologically, they are gram-positive cocci arranged in grape-like clusters. No, some in tetrads, some in singly, no, some in chains. They are motile, non-spore former, few are encapsulated, and can survive in the presence or absence of oxygen. So therefore can be aerobic on facultative and anaerobes. No? This is how they look like under the electron microscope on the left side and on the right side of your screen. I guess you're already familiar with this. No? The characteristic reaction of Staphylococcus aureus under the light microscope. Gram-positive cocci arranged in clusters. Biochemically, they are catalase positive, which will separate them or differentiate them from streptococci. So remember that. Remember catalase test. That's always being asked. The single test that will separate or differentiate strep from staphylococcus, that is catalase. So staph are catalase positive, whereas streptococci are catalase negative. And to differentiate it from Neisseria, Neisseria is the oxidase test. So staphylococcus are oxidase negative in contrast with the oxidase positive of Neisseria. So Staphylococcus can utilize sugar, different kinds of sugar as a source of energy, such as glucose, lactose, maltose, sucrose, and mannitol. If you can see there, mannitol is highlighted in green, in red colored font, the red font. Why? Because mannitol also carries with it a diagnostic significance. This will differentiate Staphylococcus from all Staphylococcus. Only will differentiate Staph aureus from all other Staphylococcus. Only Staphylococcus aureus is capable of utilizing mannitol as a source of energy. Did you get that? Huh? Lagi din tinatanong yan. Mannitol fermentation test. tests. So other biochemical tests in the identification of Staphylococcus, as you can see here, they're mostly positive except for indole tests. Methyl red is positive, Boltzmann-Scour, urease, phosphatase, DNA is positive except for indole. No? They produce pigment. At least 90% of Staphylococcus aureus produce the pigment staphyloxanthin, which renders them golden yellow in color. Now, they are relatively resistant to drying, heat, and sodium chloride. So this property of Staphylococcus, is that they develop resistance to antibiotics rapidly. They are naturally susceptible to virtually every antibiotics that has ever been developed, but at the same time, they are also notorious for its ability to become resistant to antibiotics, thus making treatment complicated by the limited drug options. So they can easily develop resistance against antibiotics. They grow, and here they can grow readily and on most bacteriostatic media. The colonies appear as round, smooth, raised, glistening, and pigmented on solid media. Pigmented on solid media, but colonies are non-pigmented if isolated in an aerobic environment or in a broth. The colonies on solid media, for Staph aureus, they appear as gray to deep golden yellow colonies because of the staphyloxanthin. Staph epidermidis are gray or white, have gray or white colonies. This species here, although non-medically insignificant, Staph citrus have lemon yellow colonies. So here are the 5 medically important species of Staphylococcus. You have aureus, epidermidis, saprophyticus, hemolyticus, and hominis. Of all of this, the most common staph pathogen and the most problematic species is Staphylococcus aureus. As you can see here, it's singled out. It is singled out. All other Staphylococcus species are referred to as coagulase negative Staphylococcus, or CONS, coagulase negative Staphylococcus. So Staph aureus is singled out. It's the most problematic. It's the most virulent of all species of Staphylococcus. These 3 here can be found as part of the normal human microbiota. These are the more common, can be normally in some areas of the body. So here's a summary of the 3 medically important ones. You see here Staphylococcus, 75%. It's responsible for 75% cases of staphylococcal infection. It's part of the normal flora of the nasal cavity, comprising 20 to 50%. It can cause a multitude of disease, either community-acquired or hospital-acquired, varying from a simple superficial pyogenic infection to serious systemic infection involving almost all organ system. The infection can be acquired through direct infection or secretion of wide variety of exoproteins, such as hemolysis, enterotoxin, toxic shock syndrome. So later on, we'll have a rundown of those different exoproteins and virulent factors. It's the most virulent of all the species. It's most purulent of all the cocci, and it's most problematic. While the other 2, the Staphylococcus epidermidis and Staphylococcus saprophyticus. So for epidermidis, it's also known as Staphylococcus albus. it comprises 60 to 70% of the normal flora of the nasal cavity, the skin, particularly the skin. Now, it's the predominant normal flora in the skin, also of the respiratory tract. It can also be found in respiratory tract, gastrointestinal, and genitourinary tract. No? While saprophyticus is part of the normal flora of the female genitourinary tract, perineum, and GIT. So that's why here saprophyticus, it's the second most common cause of honeymoon cystitis, secondary to E. coli. But these two species here are considered significant opportunistic pathogen, associated with infection from medical devices, such as, or otherwise termed as invasive medical device association, such as catheter-related UTI, shunt infection, native valve endocarditis, prostate joint infection, and other wound infection. Now, they are common nosocomial pathogen of infection from medical devices. Now, okay. Here is a summary of the morphology and biochemical differences of this staph species. So take note of the colonies. So this one, hemolysis test. This will differentiate Staph aureus from all other Staphylococcus. Only Staph aureus is capable of utilizing RBC as a source of energy also. It's the only one that can cause hemolysis of RBC. No? The type of hemolysis is particularly beta hemolysis. So there are three types of hemolysis. You have the beta hemolysis, the alpha hemolysis, and gamma hemolysis. Alpha hemolysis is incomplete destruction of RBC, wherein green discoloration around the colonies. Then green discoloration of the agar, the blood agar plates. Now around the colonies, while beta hemolysis is destruction, so you see a translucent or clear zone around the colonies. While gamma hemolysis is basically no hemolysis. Now, so for this, Staphylococcus aureus is the only one capable of, is the only species capable of hemolysis. No? And what other here? So, as mentioned, catalase test to differentiate them, to differentiate the genus Staphylococcus from genus Streptococci. No? And here, coagulase test, as you can see earlier, all other staph are referred to as coagulase negative. Only Staph aureus is capable of secreting the coagulase enzyme. Kaya positive yan, all the rest are negative, as well as the clumping factor, positive yan, all the rest are negative. Mannitol, I've mentioned it already. Only Staph aureus is able to utilize mannitol. But this one, novobiosine test. This is a presumptive or susceptibility test for Staphylococcus epidermidis. This novobiosine test is a susceptibility test that will differentiate epidermidis from saprophyticus. Again, it's considered as a presumptive test for Staph epidermidis. Okay, and phosphatic. Okay. Sources of infection of Staphylococcus. So you may get it from shedding of human lesions. You may get it from contaminated fomites and from human respiratory tract and skin. Now, through how? The portal of entry, through direct skin-to-skin contact with an infected person, or by direct exposure of cuts or abrasion with a contaminated object, or by inhaling infected droplets dispersed by sneezing or coughing. But, the bacteria may stay localized in the area of inoculation, but can spread through the bloodstream and infect distant organs. this is the boring part. No, the pathogenesis, the different adherence, virulence, and antigenic factors. So let's just have review, look at some of them. No, let's start with the cell wall associated structure. So mostly these cell wall structures or components are responsible for adherence. Some primarily for adherence, some will have an antigenic function, and some are with virulence function. So first is the peptidoglycan layer. No, it is considered as the major structural polymer of gram-positive organism. So the action, it forms a rigid exoskeleton for the cell wall. It can activate the complement system. It can elicit immunologic response. It's a chemoattractant for polymorphonuclear cells, and it has an endotoxin-like activity. Then you have the teichoic acid, also has a role in attachment and adherence. And this one, the polysaccharide capsule or slime layer or glycocalyx, has an anti-phagocytic effect, chemotactic adherence, and increases water retention. Serotypes 5 and 8 is mainly responsible for majority of infection and invasive diseases. This is the component responsible for adhering to catheters and other synthetic materials found on Staphylococcus epidermidis and saprophyticus. Now, so this is for Staph epidermidis and saprophyticus. This is important in adherence, in causing the disease, responsible for adherence, this component here, the polysaccharide capsule. And then this one, the microbial surface component recognizing adhesive matrix molecules, ang haba. Okay. So there are two, the clumping factor, clumping also responsible for adherence. Adherence that can elicit a strong immunologic host response. So there are two types of coagulase enzyme, the bound coagulase and the free coagulase. For bound, so clamping factors is primarily detecting for clamping factor, the main enzyme responsible for this is the bound coagulase enzyme. Now, it's detected by a slide coagulase test. It reacts directly with fibrinogen, causing clumping in the presence of plasma. Does not require coagulase reacting factor, unlike the free coagulase enzyme. Now, protein A, so this is found on surface of Staph aureus only. So it is used to identify Staphylococcus, the protein. Okay, and then we have the extracellular enzyme. So here, the free coagulase, the other type of free coagulase. The coagulase enzyme, particularly free coagulase. Okay, the bound coagulase. Now, for coagulase, we speak of the free coagulase part. Now, this is marker for virulence. Production of this correlates to invasiveness of the infection due to its anti-phagocytic effect. It is considered as the best single test to identify pathogenic Staphylococcus aureus. How? The action, it clots plasma by reacting with coagulase reacting plasma to form thrombin that enables the conversion of fibrin using a tube coagulase test. The other thing is slide coagulase test. Okay, what else? You have the catalase enzyme. I mentioned it converts differentiate staph from strep. How? By converting hydrogen peroxide to water and oxygen. Lipases is responsible for abscess formation, which is the hallmark of a staphylococcal skin lesion. No, yung mga pyogenic skin, that's hallmark infection. No, it liberates acid, causes irritation, hyaluronidase enzyme is primarily responsible for spreading the spreading of the infection. No, this is a mucin splitting enzyme that hydrolyzes hyaluronic acid in connective tissue and ground substance. You have staphylokinase, fibrinolysin, also dissolved fibrin clot resulting to bleeding. And then number 6, this is an important component of our enzyme of Staphylococcus, the beta-lactamase or phenylsilase enzyme. So the secretion of this will lead to antibiotic resistance. This will confer antibiotic resistance. So that one, kaya very common that you see resistance towards antibiotic. That is the one responsible, beta-lactamase or phenylsilase enzyme. And then the toxin, there are different toxins. Can be classified as one, enterotoxin. You have the enterotoxin, pyrogenic exotoxin, cytolysine, and toxin. So over them one by one. Enterotoxin. The toxin are all considered as super. Enterotoxin A to E is mainly responsible for staphylococcal food poisoning. Staphylococcus infection are classified into 5 manifestations. So one is staphylococcal food poisoning. The main exotoxin responsible is enterotoxin. No, enterotoxin can be A, can be B, and A and B. So while fever associated with staph due to exotoxin, it releases interleukin-1 and interleukin-1 and 6 and alpha-2 mononucleosis. It causes fever, capillary leak, circulatory collapse, and shock. And then you have this, the toxic shock syndrome toxin. And another manifestation of staphylococcal infection is the toxic shock syndrome due to the secretion of this exotoxin, the toxic shock syndrome toxin, formerly known as exotoxin C or enterotoxin F. It's also a super antigen. But this toxin is not only secreted by Staphylococcus aureus, it's also secreted by Streptococcus pyogenes. So somehow there is similarity in the manifestation of Staph aureus and Streptococcus pyogenes, the secretion of this toxic shock syndrome toxin. So clinically, the presentation of the patients presentation will have fever, shock, and multi-system involvement. How? Now, this toxin binds to major histopathology complex class 2 molecules, stimulating T cells, which give rise to manifestation of toxic shock syndrome. No? A system involvement. Then you have this, the cytolysine and hemolysin, which causes tissue destruction and abscess formation. All blood cells are all is affected. No, it's toxic to all blood cells, RBCs, WBCs, and platelets. There are 3 types: the alpha, the beta, and beta. The alpha has a dermonecrotic activity. The also known as sphingomyelinase C, it's high heat labile. It destroys sphingomyelin around the nerves, whereas the delta is thermostable. It disrupts cellular membrane by detergent-like factors. So marami pa, ito pa, dalawa pa. Yes, 2 more. The exfoliative or epidermolytic toxin. So another clinical manifestation of staph is the staphylococcal scalded skin syndrome, no? And the toxin mainly responsible for that is this one, the exfoliative epidermolytic toxin. There are two types, the toxin A, which is chromosome mediated and heat stable, in contrast with the exfoliative toxin B, which is plasmid mediated and heat labile. Those two responsible for the staphylococcal scalded skin syndrome. And lastly, you have this, the Pantone Valentine leucocidin toxin, also an important virulence factor for a community-acquired methicillin-resistant Staphylococcus aureus. It lyses RWBC by causing pore formation in the cellular membrane, increasing cation permeability, releasing interleukin-8, leukotriene, and other substance causing necrosis and severe acid inflammation. It is associated with furunculosis and nucleotizing pneumonia. So those are just some of the virulence, antigenic, and adherence factors of Staphylococcus that may lead to the different manifestation. These are the different manifestation of Staphylococcus aureus. No? It can cause a multitude of disease, which may vary from a superficial pyogenic or pus-forming infection of the dermis and underlying tissue to serious systemic infection. No? We may classify them into 5. The localized cutaneous one is the localized cutaneous infection. These are your pustules, your boils, your carbuncles, abscess, impetigo, and so on. No? Localized cutaneous infection. And then number 2, we have, so this localized cutaneous infection, if not treated properly, becomes more infected, may lead to a systemic deep infection, no? Such as osteomyelitis, tonsillitis, pharyngitis, and so on. This any organ system can be involved, no? And number 3, this may be Staphylococcus may present as food poisoning, toxic shock syndrome, and staphylococcal scalded skin syndrome. How are so these are examples of localized skin lesions of Staphylococcus. Yan, furunculosis, yung mga pimple nyo, infected pimple nyo, abscess, folliculitis, and so on, no? Usually involving the hair follicles. So how are they formed? How is this formed? So this is more common among adolescents and during prolonged steroid therapy. No? So it is the bacteria or the bacterium is transmitted usually through a direct skin-to-skin contact. The staph aureus then which will then colonize the hair follicle, which will lead to tissue necrosis and production of the coagulase enzyme. So this coagulase enzyme will coagulate fibrin around the lesions and lymphatics, resulting in a fibrin wall, no? Resulting in a fibrin wall which is reinforced by inflammatory cells and fibrous tissue. Kaya around the lesions, the periphery of the lesions, it's rigid or matigas because of that fibrin wall. And at the center of the lesion will undergo liquefaction of the necrotic tissues. So there is central necrosis or central liquefaction enhanced by delayed hypersensitivity, which will eventually lead to abscess or focal suppuration. So yan. So yung gitna, it's soft because of liquefaction of the necrotic tissues, which will lead to abscess formation. No? Drainage of that abscess, drainage of that center or abscess will lead to formation of granulation tissue within the cavity of the lesion, which will mark the start of healing of the lesion. If it gets infected further, the localized skin infection may eventually disseminate to other organ system. Now, from any one focused organism may spread via the lymphatics and the bloodstream to other parts of the body, where suppuration will occur within the veins associated with thrombosis, leading to bacteremia, sepsis, osteomyelitis, pneumonia, meningitis, and so on. Okay, so that is how you get disseminated infection from Staphylococcus. How do you get food poisoning from Staphylococcus? So food containing protein is cooked. During the cooking process, the bacteria is killed. No? It's susceptible to heat. Right? So it's killed. But when food is then handled by a contaminated worker, so with probably contaminated hands, you get it's contaminated again. So, and if left at room temperature, this will allow for growth of the organism. Reheating the food may kill the staph, but it will not destroy the toxin. So the one responsible for the disease is the toxin released by the bacteria. So ingestion of the contaminated food may eventually lead to staphylococcal food poisoning within 1 to 6 hours. And this is clinically manifested as severe crampy abdominal pain, nausea, non-bloody diarrhea, although there is no fever. This condition is self-limiting with rapid convalescence of 6 to 8 hours. So simple lang naman pala siya. It can be resolved without any medication. No, but this is the more serious sequelae of Staphylococcus, toxic shock syndrome. Again, due to the secretion of the exotoxin, toxic shock syndrome, toxin 1. No? This will result in shock and multi-organ system failure. Does not only secrete by Staphylococcus aureus, but also by group-A Streptococcus pyogenes. So mentioned ko na yun. Mortality rate can be higher than meningococcal septicemia and associated with high absorbency tampons in women. Yeah. So presentation, the clinical presentation, you have an hypotension, fever, chills, diarrhea, and rash and desquamation or scarletiniform rash, no? Such as this one. See, halos red na yung buong katawan niya because of the rash. Yeah, so fever, hypotension, fever, multi-organ system, and shock. Toxic shock syndrome. So if you want to study this diagram here, so you may, pero I'll just move forward. No? Okay, another manifestation is called, this is the last one, the staphylococcal scalded skin syndrome, also known as exfoliatin or epidermolytic toxin or Ritter's disease. It is a syndrome of acute exfoliation of the skin, typically following an erythematous cellulitis. Severity may vary from few blisters localized to the site of infection to a severe exfoliation affecting almost the entire body. This is due to secretion of the toxin, the epidermolytic toxin. Diba? There are two types of that. You just go back to our previous slides for that. No? So how it causes intradermal splitting of tissue, disturbing the adhesive cells in the stratum granulosum. It's common among newborn and elderly. So ito ang itsura ng staphylococcal skin. Okay? So how to diagnose? Internet connection is unstable. Unstable pa ba? Can you still hear me clearly?
Yes, Doc.
Okay, so kasi may nag-prompt. stable daw ang internet connection. So how to diagnose or how to identify or isolate Staphylococcus? You have the culture. It grows readily on most bacteriostatic media, no? On nutrient agar, it's golden staph, particularly Staph aureus, it's golden yellow. On blood agar, it's also golden yellow colonies surrounded by a clear zone of hemolysis because of the hemolysin enzyme. And on McConkie, you have the colonies are pink in color due to lactose fermentation. And of course, we have the typical gram-positive cocci in clusters to suggest Staphylococcus aureus. So on your right are the agar with clear hemolysis or beta hemolysis surrounding each colonies, and on the right side you have the gram stain. To identify species, we do different biochemical tests. This you will do in your lab, or you will also again discuss in your laboratory. The schematic diagram or the schema, start by doing a catalase test to differentiate with or differentiate it from Streptococcus. So catalase positive, Staphylococcus, then you perform coagulase, mannitol, and hemolysis. So this test here will differentiate staph. So you get a positive test for Staph aureus, and all that are. So under this, the coagulase negative, you then, to differentiate epidermidis from saprophyticus, you do the novo biopsy, which is a presumptive test for Staphylococcus. Okay, this is how they will look like. No, we start with catalase test. Class, kung nakikinig kayo, this one is mali. This should not be coagulase negative staph. This should be Streptococcus. Hindi ko ma-edit eh. Hindi ko ma-edit. Hindi ko siya ma-edit. No? So, just kayo na mag-edit niya. This should be Staphylococcus. So, catalase test upon hydrogen peroxide. You see a bubbling formation there, formation of bubbles, that is positive. No? That's the positive result. Indicate probably Staphylococcus. No bubbles, that's. Then you perform coagulase test using the tube test, the tube coagulase test. Formation of gel at the bottom of the tube in the presence of plasma. So that is a positive result which will indicate Staphylococcus aureus. If action, coagulase negative. Do a mannitol fermentation test. Mannitol fermentation agar is both an enriched and a differential medium at the same time. No? So as an enriched medium, this will support all Staphylococcus. This will support all growth of Staphylococcus while it will inhibit Streptococcus. No, mali. Okay. Again. As an enriched medium, this will support growth of all gram-positive while inhibiting gram-negative. No? So lahat ng gram-positive will grow on mannitol agar, mannitol salt agar. No? But as a differential medium, only Staphylococcus aureus is capable of utilizing the change in the pH. You see the change in the pH there is observed by the change in color of the agar from pink to yellow. So a change in color from pink to yellow will suggest utilization of mannitol, no? As exemplified by Staphylococcus aureus. So here, all the rest are negative. And you have the hemolytic test here, ito, beta hemolysis. So, you cannot really appreciate it unless you put it against a light. Doon mo lang only then you would appreciate yung translucency or the zone of inhibition around each colonies. All the rest are gamma hemolysis or no hemolysis. So here, just summarize everything I have said in this table and on this table as well. Okay, and these are the criteria for identifying pathogenic strains of Staphylococcus. You have a golden yellow pigment, hemolysis on blood agar, coagulase test positive, catalase positive, mannitol positive. Well, those are the more important ones. So the more readily available tests for Staphylococcus aureus. Treatment, well, depending on the manifestation, no, for a simple skin or pyogenic infection, a local antisepsis may suffice, such as fusidic acid or mupirocin. No, favorite ng daughter ko yung mupirocin na yan. Okay. For abscess, well, depending on the severity of the abscess. If these are just small abscesses, no, cloxacillin or oxacillin may suffice. Cloxa is oral, oxa is IV. So antibiotics may suffice, but for bigger abscesses, you may need to drain them to remove the abscess so that it will give way for healing. No? Yung formation of granulation tissue at the center of the lesion. So, yan. So, depende kung gaano kalaki. For osteomyelitis, for acute, you need, you need drainage. For abscesses, you need to drain them and give cloxacillin after. Now, for osteomyelitis, you have also antimicrobial therapy. Surgical drainage or debridement may also be required. Long-term antibiotic therapy. So this one, for non-beta lactamase producing enzyme, the drug of choice is penicillin G. For my lectures, I just usually ask kung ano yung drug of choice. Although some of my lectures, nakasulat pa kung anong dose, it's written there what dose to use, yung mga dosages, no? But usually I just ask the drug of choice. So at this level, enough that you know the drug of choice. Maybe when you reach your third year level, that's when you're going to memorize the dose and the everything else. No. So here, sa level ko, enough na yung drug of choice. Okay. So if this is the first initial infection, the drug of choice, very effective ang penicillin G. But for repeated infection, you may the risk of developing resistance to methicillins is higher. So then baka doon you like other drugs, penicillin may not work, no? But for initial infection with staph, penicillin G is always the drug of choice. So but for more severe infection, for more severe staph infection like bacteremia or methicillin-resistant staphylococcus and other severe infections such as endocarditis, no, you give beta-lactamase-resistant penicillin such as vancomycin, no, or daptomycin or linezolid, no? Okay, and so I've been mentioning methicillin-resistant staphylococci. This is due to either production of the beta-lactamase enzyme, but aside from that, it may also be due to production of, wait lang class, kaya pala ako nadidiliman, wala akong video. It can also be due to production of penicillin binding protein 2A encoded by the MECA gene. So that one, those are mainly the reasons for methicillin-resistant staphylococci. There are different classifications, no, of methicillin-resistant staphylococci. Ay, ano pa ba nakasulat dito? Well, the MECA gene can be detected via cefoxitin diffusion or dilution method, while the beta-lactamase enzyme can be detected via use of the beta-lactamase inhibitors such as clavic acid, no? Also on this diffusion method. So there are different classification of methicillin-resistant staph. You have the community-acquired, you have the vancomycin-resistant, you have the vancomycin and hospital-acquired methicillin. This is the most commonly encountered, the community-acquired, but the most worst outcome is the hospital-acquired methicillin resistant. Okay, so okay, so you just read on what's written there. No, what do I usually ask? So for this one, community acquired, you have these are due to the leukocidin Panton Valentine leukocidin gene and the Staphylococcus cassette chromosome or the MECA gene. Now production of the leukocidin gene, the Panton leukocidin gene, and production of the MECA gene. No? So what else? This one. Unlike this one, it doesn't have this leukocidin gene. No? Okay, let's just move forward. Just remember community-acquired methicillin resistance. So again, at this level, enough na siguro you know that there are different forms of or methicillin-resistant staph can occur. Okay, so Streptococcus. Oh, that's 1 hour already. It's 4 o'clock na. Mas bibilisan ko na. Ang haba pa naman to Streptococcus. Okay, belonging to the family Streptococcus. There are under those species, those are the more important species of Streptococcus. Streptococcus pyogenes, Streptococcus pneumoniae, Streptococcus agalacea, Enterococcus, and the viridans group. Morphologically, they are gram-positive cocci arranged in chain, some in singly, some in pairs. Also, they are aerobic or facultative anaerobic, non-motile, non-spore forming, and part of the normal flora of the oropharynx and gastrointestinal tract. They have a complex nutritional requirement. They grow on culture containing blood or serum or fermentable carbohydrates. Growth and hemolysis at 37 degrees C with 5 to 10% carbon dioxide at neutral pH. They are catalase negative, but some species or strains of Enterococcus faecalis are weakly catalase positive for producing pseudo-catalase. Streptococcus are classified into different ways, no? So first, we may classify their clinical presentation. So some are pyogenic, some are oral, and some are enteric, no? Or we may also classify based on their physical or their biochemical reactions. But the more what's the word? Nawawala ako paminsan. The more popular classification is this one, serological classification and hemolysis. The old classification, the hemolytic classification. So based on the type of cell wall present on there, the type of carbohydrates the type of carbohydrates present on this cell wall, they may be classified as to this Clansfield classification from group A to U. Ang dami yan, A to U. So we just remember A, B, C. Those are the more important Clansfield classification of Streptococcus. Group A strep, Group B strep, and Group D strep. Okay? And then this one, also a more famous classification, is based on their hemolytic reaction on blood agar. You have the alpha, the beta, and the gamma. So na-mention ko kanina, alpha, here, I'll show you. So alpha suggests incomplete hemolysis or incomplete rupture of RBC. So you see a greenish discoloration around the colonies. So green yan, kulay green yan around the colony. So beta hemolysis is complete hemolysis. No? You see there a zone of inhibition around the colonies. So translucent, if you put it against, place it against light. No? And gamma is no hemolysis. Alpha hemolysis do not have a group antigen to this classification. They have no classification, no group antigen. So this include the more species are Staphylococcus pneumoniae, Streptococcus mutans, and Streptococci under alpha hemolysis or alpha classification. Hemolysis are those belonging A and group B of the Lancefield classification. Okay, and group and gamma hemolysis are those belonging to group D Lancefield classification. So under niyan enterococci, group D enterococcus and non-enterococcus group. Okay? Are we clear here?
Yes.
Huh? Wait, I'll just get water. Class, do you prefer online or face-to-face? Now that you have some face-to-face classes, which do you prefer? Online or face-to-face? Face-to-face po. Oh, don't be shy to speak up. Nag-chat ba? Ay, kuminsan hindi ko online. Online. Oh, some face-to-face, some online. I don't know if we will continue with blended teaching if after this sem. Well, it has its pros and cons, but overall, I don't know which is better. But of course, for skills, mas maganda pa rin ang face-to-face, no? Okay, so this just a short break there. Hi, where are we? Hemolysis. Okay, so here, just summarize it here. Under group A, Lancefield classification with beta hemolysis, the most important species is Streptococcus pyogenes. So this is also referred to as not gram positive, group A beta hemolytic strep. So Streptococcus pyogenes is synonymous to group A beta hemolytic strep, or gas. So group B, you have Streptococcus aguilaceae. So group B, beta hemolytic, Streptococcus aguilaceae. Never mind group C. Group D, Enterococcus faecalis, no, with gamma pattern. Never mind this. No capsular antigen, so they do not have a Landsfield classification. With alpha hemolysis, you see you have their Streptococcus pneumoniae. The other viridans group, Streptococcus viridans and other viridans group, they may show alpha and gamma hemolysis. No. So what else? Okay, this one. So you see there, they're differentiated by hemolysis. Alam nyo na yan. The optogene test, again, is a susceptibility test as a presumptive test for Streptococcus pneumoniae to differentiate it from other alpha hemolytic strep. While bacitracin is a susceptibility presumptive test for Streptococcus pyogenes that will differentiate it from other beta hemolytic Streptococcus. So here are the three important species: Strep pneumoniae, Strep pyogenes, and Enterococcus faecalis. In the laboratory, this is what you're going to do. The different biochemical tests to identify different species of strep. Again, you start with catalase to differentiate with Staphylococcus. Then you do hemolysis. So their alpha hemolysis will either suggest Streptococcus pneumoniae or viridans group streptococci. Now, to differentiate strep pneumoniae from other viridans group, you do an optogene susceptibility test or TAXO-P. It's a presumptive test for Streptococcus pneumoniae. So susceptible dyan is to pneumoniae. Viridans, negative, no? They're resistant. Under this group, the beta hemolytic strep, you have the group A, Streptococci, also known as Streptococcus pyogenes, and you have the group D, Streptococci. To differentiate pyogenes from the group B, you do a bacitracin susceptibility test or TAXO-A, which is a presumptive test for Streptococcus pyogenes. Group B are resistant. So under this group here, under this column, you have the group D, Streptococci, which will give you gamma hemolysis. To differentiate Enterococcus faecalis from non-Enterococcus group B, you do a salt tolerance test. No? Enterococcus faecalis is not, growth of Enterococcus faecalis is not inhibited by a high salt concentration, where all the rest, all the other non-Enterococcus group B, their growth is inhibited by presence of high salt concentration. So, okay, so Streptococcus pneumoniae, let's look at it more closely. Strep pneumoniae, morphologically, it's also known as pneumococcus, no? Or Diplococcus pneumoniae, with more than 90 different serotypes. For adults, the more common serotypes are types 1 to 8, while among children, you have type 6, 14, 19, and 23. So vaccines available are directed toward this serotype. No? It's a normal flora of the nasopharynx comprising 5 to 40% in the upper respiratory tract. 40 to 70% of humans are natural carriers of Streptococcus pneumoniae in their upper respiratory tract. And it accounts for 60 to 75% of all bacterial pneumonia. In short, it is the most common cause of bacterial pneumonia, no? Especially those requiring ICU. Okay? So they're gram-positive diplococci, lancet shape in singly or in chain. What else? Growth is inhibited by optogene. It can ferment glucose and lactic acid. So under the electron microscope, you see the diplococci there, no? And on light microscopy on your right side, gram-positive diplococci shape. Okay, so just a rundown of the different virulence and adherence and antigenic factors of Streptococcus pneumoniae. Nakakaantok to. So we start capsule, the capsule or the K antigen present on the cell wall. So you see the capsule has always an antiphagocytic function, no, that produces immunity. So based on this capsule, there are more than 90 different serotypes, which can be identified by the Neufeld-Quellen reaction. So that's what the test use to identify the different strains. Then you have the somatic O antigen, no? Also responsive with antiphagocytic effect, responsible for adherence and for agglutination. The F antigen, the M protein, so never mind those. The choline binding protein A or pneumococcal surface protein, also part of responsible for adherence, and other enzyme, neuraminidase, proteases. Okay, the toxin, pneumolysine O, and autolysine. So just please kindly read on them, no? The presence of the pili or hair-like structure that extend from the surface that contributes to colonization of the upper respiratory tract and increase the formation of large amount of tumor necrosing factor by the immune system during sepsis, which may lead to septic shock. And you have hydrogen also, hydrogen peroxide, which causes damage to the host cells with a bactericidal effect. Ito na. This is more important na lang to. So this strep pneumoniae accounts to 1 to 8, serotypes 1 to 8 accounts for, again, 75% of bacterial pneumonia in adults, with more than 50% mortality from pneumococcal bacteremia. Among children, the more common serotypes, 6, 14, 19, and 23. Tandaan nyo yan. Ha? Tinatanong ko yung mga serotypes na yan. The leading cause, so if in adults, this is the most common cause of bacterial pneumonia. But in children less than 5, this is the most common or leading cause of bacterial meningitis. So take note. Huh? Less than 5, it's the leading cause of bacterial meningitis among children less than 5 years of age. It's also the most common cause of otitis media in children. And it's the most common cause of pneumonia requiring ICU among adults. No? So in children, from the nasal cavity, from the normal flora in the nasal cavity, they may gain access in here in the ears, causing otitis media, or they may gain access to the brain, causing bacterial meningitis. Okay. Mode of transmission is direct person-to-person contact with contaminated respiratory secretions. Predisposing factors, so just read on that. Pathology, how is this the disease is formed? Through what? Fibrinous edema fluid floods the alveoli, followed by red cells and leukocytes forming alveolar consolidation, which is appreciated on a simple chest X-ray. Excuse me. Bacteria then invades the bloodstream via the lymphatics. The mononuclear cells, it's okay. The mononuclear cells phagocytose the debris and the exudate is reabsorbed. Pneumococci taken up by phagocytes and digested intracellularly, causing sorry. Pag dire-diretso ako nagsasalita. My throat is irritated. So where are we? So there. So from here, mononuclear cells phagocytose the debris and distributed to other organ system. No? So there are basically 4 manifestations of Streptococcus pneumoniae. You have pneumonia, lobar or bronchopneumonia, clinically manifested as sudden onset of fever, chills, dyspnea, tachypnea, productive cough, blood tinged sputum or with rusty colored sputum, and sharp pleuritic pain. This may lead to pleural effusion and empyema. So that's 1. Pneumonia. Number 2, you may have, this may be manifested sinusitis or otitis media, which is usually preceded by a viral infection. No? And this one may lead to mastoiditis, may have a sequela, which may lead to mastoiditis or meningitis. No? Or you may have a primary bacteremia, no, without known site of infection. So it's a common clinical presentation which may also lead to meningitis, endocarditis, peritonitis, and septic arthritis. Or bacteremia can be secondary to pneumonia. So you may have a primary bacteremia or a secondary bacteremia from pneumonia, no, or otitis media or from meningitis. And finally, this may be presented as meningitis, primarily as meningitis, whether primary or secondary meningitis. So culture on blood agar plate, and so gram stain, no gram stain, biochemical test, so just this one, the optogen, just remember this one, optogen or taxopi susceptibility test as a presumptive test for Streptococcus pneumoniae. Or you may also do bile solubility test. Other serologic tests, so never mind that. So this is how, susceptibility test for taxo-P. There is a measurement there. The zone of inhibition, I forgot kung ilang measurement. Wait, class, let me see. Hindi ako magpapakali. There's a measurement yan. So optogen test, optogen ba tayo? Nasa optogen ba tayo? Should be more than 14 millimeter. For optogen. Optogen should be, okay, the zone of inhibition, the zone, do you still see my screen? Nakikita niyo pa ba? Do you still see it?
Yes,
Okay. So the diameter, the zone of the diameter of the zone of inhibition should be more than 14 millimeter to interpret it as susceptible. So less than that, resistant. Okay? Sulit mo na kaya. Parang hindi ko na makalimutan. Okay. What else? This is the Neufeld quelling reaction, no? To identify the type of strain or the type of capsule. So treatment, the drug of choice is still penicillin G. Right? Vaccination, you have 2 types of vaccination. The PCV7 or the pneumococcal conjugate vaccine. PCV7, why PC7? Because it's effective against 7 serotypes. No? You see it's red, it's in red, it's in red font. So kaya yan, usually I ask that. This is to prevent bacteremia, meningitis, and otitis media in children. It's part of the routine vaccination of children less than 2 years old and children to 24 to 15 months with high-risk medical condition. No? Doses are given at 2, 4, 6 months with booster dose at 12 to 15 months. So this is the vaccine you give for less than 2 years old. While the vaccine more than 2 years old and for adults more than 65 years old, you give the pneumococcal polysaccharide vaccine or PPV23. So it's effective against 23 strains. No? So recommended for adults more than 65 years of age and children more than 2 years of age. So yung mga bata that they miss pneumococcal vaccine before the age of 2, you give them this one, the pneumococcal polysaccharide vaccine. So you give it that with booster given at 5 years interval after 5 years after receiving the initial vaccine. So this one, the PPV23 is not given to children less than 2 years old. Instead, you give PCV7. Okay. Chemoprophylaxis, well, with oral penicillin for patients with hypogammaglobulinemia or patients that undergone splenectomy. You give prophylaxis with oral penicillin. Then number 2, Streptococcus pyogenes. So 4:30 na. Meron pa akong Neisseria. Streptococcus pyogenes, it causes, so manifestation is somehow similar to Staphylococcus aureus. It causes a wide variety of diseases in humans, from transient asymptomatic colonization of the oropharynx and the skin to severe life-threatening diseases such as rheumatic fever. So remember, rheumatic fever, scarlet fever, acute glomerulonephritis, and invasive bacteremia. It's the main human pathogen in local or systemic invasion or post-streptococcal immunologic disorder, also known as the flesh-eating bacteria that may cause extensive necrosis of subcutaneous and muscular tissues and adjacent fascia. Morphologically, they're gram-positive cocci in chain of various lengths. So this one on electron microscope and on microscopy. So the different exotoxin, or different virulence factors. One is the M protein toxin or M protein antigen, which is their main virulence factor. There are 2 types. So these are macromolecule incorporated in fimbriae or hair-like surface protein on the cell membrane projecting on the cell wall. There are 2 types, the class M1 protein. This is the one associated with rheumatic fever, and the class 2 M protein is the one associated with glomerulonephritis. To some extent also rheumatic. It may cross-react also with heart tissue to cause rheumatic fever, but primary for glomerulonephritis. Class 1, primary for rheumatic fever. Class 2 for glomerulonephritis. No? Then you have the T protein antigen. It's not a virulence factor, but it's used as an epidemiologic marker for routine surveillance. The C carbohydrate proteins, the basis of the Landsfield grouping of streptococci. Streptokinase, it's used, so this one, it acts as a fibrinolysin that turns plasminogen to human plasma into plasmin. This is sometimes used an IV treatment for pulmonary embolism and coronary artery disease and venous thrombosis, streptokinase. Streptodornase type A to D is a DNase enzyme that digests neutrophil extracellular traps and degrades DNA to facilitate local spread of streptococci in tissue by liquefying fast. It's associated with pyoderma in impetigo. Hyaluronidase, the role is a spreading factor. This one, so never mind that one. Oh, okay, this one, the streptococcal pyogenic exotoxin or erythrogenic toxin. The toxin mainly responsible for scarlet fever, toxic shock syndrome, and flesh-eating fasciitis. Okay, so it's a super antigen. causing scarlet, toxic shock syndrome, and flesh-eating fasciitis. Then you have the hemolysin, no, responsible for destruction of RBC. There are two types, the streptolysin O and the streptolysin S. The streptolysin O is oxygen level, responsible for causing RBC destruction deep in the medium of the agar plate, no? While streptolysin S is oxygen stable, non-immunogenic, non-antigenic, responsible for hemolysis of blood on the surface of the blood agar plate. Now, streptolysin O, it also combines with, this is the basis, this is what we use to detect for or to determine the titer of the infection. No? So combines with anti-streptolysin O or the ASO titer, form the antibody that form after streptococcal infection. So a titer of 160 to 200 suggests a recent infection or an exaggerated immune response to an earlier exposure in a hypersensitivity patient. Hypersensitive patient. Okay. Then what else? So that's, well, some of the more important virulence factors. So epidemiology, so Streptococcus pyogenes accounts for most streptococci containing group A antigen. It is considered as the most common bacterial cause of acute pharyngitis or sore throat in children 5 to 15 years of age. Kaya pag may patients complaining, children complaining of sore throat, think of Streptococcus pyogenes. It's also the most common cause of cellulitis and erysipelas. No? Disease can be suppurative or non-suppurative in nature. Mode of transmission, it is transmitted to direct person-to-person contact with contaminated respiratory secretions. Now, the manifestation can be classified into 1, toxic shock syndrome. Toxic shock syndrome. Number 2, a simple skin infection, no, erysipelas or cellulitis, no, pharyngitis or otitis media. These are more localized infection, or you may have a systemic manifestation in the form of meningitis, arthritis, and osteomyelitis, no, bacteremia, and sequela. So all this may lead to post-streptococcal glomerulonephritis or acute rheumatic fever. Okay. Are we good? So skin infection, pharyngitis, so a simple skin infection, pharyngitis or otitis media may have a sequela of acute glomerulonephritis or acute rheumatic fever, especially in repeated infection. Okay, so pharyngitis. Okay, ano ba? So 4:30 na, no? So just go over this. Pharyngitis or septic throat or sore throat, impetigo, erysipelas, cellulitis, or necrotizing fasciitis, or no, genital infection. Paano ba to? Okay, skin, localized suppurative infection. Okay, I've classified it into localized, pyogenic or suppurative infection, and toxigenic disease, and immunologic disease. So I've classified it into 3. Okay, so localized, pyogenic or suppurative infection. So under that, you have pharyngitis or septic throat, skin infection, genital infection, and others. So pneumonia, mastoiditis, or retropharyngeal abscess. Cellulitis, erysipelas, toxigenic disease, you have scarlet fever, characterized by rash on the face and upper extremity with a strawberry-colored tongue, shedding of the skin due to erythrogenic or rash-inducing toxin, no? The pyogenic streptococcal pyogenic exotoxin, no? Responsible for the rash of scarlet fever. Or you may have the toxic shock syndrome also as toxigenic manifestation of Streptococcus pyogenes caused by the toxic shock syndrome 1. Now, the same clinical presentation of Staph aureus, hypotension, fever, chills, diarrhea, and the scarlatiniform rash. No? And immunologic disease, the sequela, the acute rheumatic fever due to class 1M protein. Onset is 2 to 3 weeks after a streptococcal throat infection. It causes inflammatory myocardial lesions of connective tissue and degeneration of heart valves, characterized by the presence of Ashkoff subcutaneous nodule. So mechanism, there's antigenic cross-reactivity between the streptococcal antigen and the heart tissue and joint, or direct toxicity by streptococcal exotoxin, or direct invasion of the heart by streptococci. So those how you can acquire rheumatic fever. Acute glomerulonephritis is caused by specific nephritogen strains of group A streptococci. It causes acute inflammation of the renal glomeruli with edema, hypertension, hematuria, and proteinuria. It's usually the sequela of both pharyngeal and pyodermal streptococcal infection. It is progressive, irreversible in young. No? Irreversible loss of renal function. So kaya it's important that to eradicate acute infection of Streptococcus pyogenes before it can cause acute glomerulonephritis. Diagnosis, you have culture, gram staining, biochemical test. This okay. So remember bacitracin, the presumptive test for Streptococcus pyogenes, and other serological tests. Ayan, this one, the zone of, basta there is a zone of inhibition, it's considered susceptible. Unlike taxope, there's, the diameter should be more than 14 millimeter. Here in taxo A, bacitracin, as long as you see a zone of inhibition, regardless of the measurement, it's considered positive. Okay. Okay, drug of choice, also penicillin G. For those with pen allergy, you may give erythromycin or clindamycin with 10-day 3 for 10 days. No? Primary and secondary prophylaxis with penicillin G IM every 21 days, no, as streptococcal prophylaxis. Enterococci, please just read on this one. Enterococci, short lang naman yan. Okay, I want to go, for the remaining time, I want to go over Neisseria. Okay? Gising pa ba kayo?
Yes po, Doc.
Yes.
Neisseria. Do you see Neisseria? Huh?
Yes.
Okay. So just quickly, let's go over this. Morphologically, they are gram-negative kidney bean shape or coffee bean shaped diplococci. They are non-motile, aerobic or facultative anaerobic, and capnophilic. So on electron microscope and here, the gram-negative diplococci. Now, the colonies grow best under aerobic condition in enriched media such as chocolate agar or modified Thayer-Martin medium. Modified Thayer-Martin medium is actually a chocolate agar mixed with some antibiotics, no? And Martin Lewis agar, containing heated blood, hermine, and animal protein with 5% carbon dioxide. The colonies, they are convex, transparent, or opaque, glistening, elevated, mucoid, non-pigmented, excuse me, non-hemolytic. Okay? And they oxidize carbohydrates by producing acid but not gas. So the oxidation or carbohydrate can be used to identify the species of Neisseria. So such as this one. So carbohydrate utilization or oxidation of carbohydrates. There are two important species of diarrhea in medicine, Neisseria gonorrhea and Neisseria meningitidis. Neisseria gonorrhea is always pathogenic. Now it's not part of the normal human microbiota. Neisseria meningitidis may be part of the normal, can be found in the normal flora. No? But then gonorrhea is always pathogenic. So using carbohydrate utilization, you can differentiate them. Neisseria gonorrhea is capable of oxidizing glucose, whereas Neisseria meningitidis can oxidize glucose and maltose. Okay. There is another species, Neisseria sicca, which can utilize naman sucrose, but never mind that. So just we limit ourselves to these two important ones, Neisseria gonorrhea and meningitis. Gonorrhea can oxidize glucose only, while Neisseria meningitidis can oxidize glucose and maltose. So that's what we mean by carbohydrate pattern used for identification of Neisseria species. No? Okay, let's move forward. Killed by drying, sunlight, moist heat, and disinfectant. This is the oxidase test of Neisseria. The positive oxidase test, you see the filtered paper with few drops of this one, the tetramethylphenyl glycol or the oxidase, no? You put it there, and the discoloration of that filter paper would suggest oxidase positive. The color of the filter paper should be purple in color. So during our laboratory, we'll show you a positive oxidase test. So face-to-face, when we're back to face-to-face, so 3 weeks from now. So here, there are two species, gonorrhea and meningitidis. Neisseria, gonorrhea always pathogenic, while meningitidis can be commensal of the upper respiratory tract. So let's start with Neisseria gonorrhea. These are some of the antigenic structure. It secretes different types of protein. Kindly read on that. And so, kayo na magbasa niyan, ha? So how is the disease formed, the pathology? So only the pileated bacteria are virulent. So it attacks the mucous membrane of the genitourinary tract, or the eye, or the rectum, or the throat, and causes acute suppuration and tissue invasion, which may lead to chronic inflammation and fibrosis. It has a worldwide occurrence. It is transmitted only by sexual contact. Humans are the only known host with incubation of 2 to 7 days. It is second only to chlamydia as the most commonly reported sexually transmitted disease. And the peak incidence is 15 to 24 years old. No? Women are at higher risk compared to men. Reservoir asymptomatic infected individuals are more commonly seen among women. Manifestation, you have genitourinary manifestation, gonococcal bacteremia, and gonococcal ophthalmia neonatorum among neonates. So for genitourinary infection, this may be presented as proctitis or urethritis, or maybe asymptomatic. Among female, the endocervix is the most commonly infected site and causes endocervicitis, or the cervix alone, cervicitis or vulvovaginitis, pelvic inflammatory disease, or salpingitis. Salpingitis is the most frequent complication, which may cause sterility from scarring of the tube. So take note of that, salpingitis. So try to avoid salpingitis from Neisseria gonorrhea. In men, this may cause prostatitis and epididymitis. Or you may have a primary gonococcal bacteremia. This is associated with skin lesions and other organ involvement, no? Meningitis, eye infection, and so on. Or the infection may pass through the infected birth canal from the mother to the neonate, causing gonococcal ophthalma neonatorum. So untreated conjunctivitis may lead to blindness. So this can be treated by administration of Creed's prophylaxis using 1% silver nitrate or 1% tetracycline or 0.05% erythromycin ointment. So this is how ophthalmia neonatorum would look like. Okay, so it's important that you administer erythromycin or treatment immediately to avoid blindness of the neonate or the newborn. Okay. Diagnosis, you have these are used as different specimens, no? Then you do culture and sensitivity, gram staining. Treatment, uncomplicated genital or rectal infection, ceftriaxone or cefixime are the drug of choice. If it has if with or synchronous or concomitant chlamydial infection, azithromycin may be given. No? So, and then prevention's read on that. And the second species, Neisseria meningitidis, the antigenic structure, the capsular polysaccharide with 13 serotype as the major virulent factor. The disease, the serotype causing disease in man are this one, A, B, C, X, Y, and Y. Y and W135. So please take note of that. And okay, so just read the other antigenic structure. So dito na lang tayo sa epidemiology. Let's move forward to epidemiology. Humans are the only known host for whom it is pathogenic. Now, the portal of entry is through the nasopharynx. So attachment to the epithelial cells in the nasopharynx through the villi, and which reaches the bloodstream, causing bacteremia and meningococcemia. There are two clinical manifestations of Neisseria meningitidis. The more common one is meningitis. So this is the most common complication. It's basically inflammation of the meninges causing thrombosis of blood vessels, and PMN, polymorphonuclear exudation, with 3-day incubation period. This is the more common complication. A rare complication is meningococcemia. This is what we're trying to avoid, especially sa mga bata. No? Meningococcemia, it's a rare infectious disease characterized by upper respiratory tract infection, fever, skin rash, and lesions, eye and ear problem. The hallmark, the clinical hallmark of meningococcemia is vasculitic purpura. This is due to the thrombus of the small blood vessels with perivascular infiltration and petechial hemorrhage. No, this may also lead to myocarditis, arthritis, and skin lesions. There are two forms, the Waterhouse-Friderichsen syndrome in fulminant meningococcemia, which develops rapidly and is more severe. And the other one is chronic meningococcemia with waxing and waning course. No? Diagnosis, you have the specimen there, blood and CSF of the specimen. Culture sensitivity, gram staining. Treatment, drug of choice is penicillin G. If allergic to penicillin G, you may give chloramphenicol, ceftriaxone, or ceftriaxone. Chemoprophylaxis for carrier states and chemoprophylaxis, you may give rifampicin 600 milligrams BID for 2 days or ciprofloxacin 500 milligrams single dose. Vaccinations are available to prevent meningitis or meningococcemia. There are two types of vaccine, the meningococcal vaccine or Menactra. It contains polysaccharide antigen A, C, Y, and W135. It's not protective against serogroup. And or the quadrivalent vaccine, also serotype A, C, Y, and W135. So those are the vaccines available for those serotype. Other Neisseria, so just read on that. Okay, so may 15 minutes pa pala ako, but I suppose we're all tired. We're all tired, no? Okay,